Could we start now?
Please start, Tanjim.
Okay. On behalf of SAFOG REI Subcommittee, I welcome you all to this very interesting webinar, which is on endometriosis and infertility. This is going to be divided into two parts. In the first part, we are going to have two very interesting keynote speeches on endometriosis and infertility. And in the second part, we are going to be having a very interactive and interesting panel discussion where everybody is welcome to give their opinion regarding different scenarios. The audience can also participate in this panel discussion in the chat box, and all the discussants as well as the keynote speakers are welcome to give their opinion. So let us start with the introduction. Let me first introduce me. I am Dr. Tansim Sabina Chaudhary, working as Associate Professor OBGYN, Bardem General Hospital and Ibrahim Medical College. I'm also the International Secretary of Fertility Sterility Society of Bangladesh and country representative of Aspire. Today, we have among us Professor T.A. Chaudhary as the chief guest of this webinar. Actually, he does not need an introduction. He has been the past president of SAFOG. He is the professor and chief consultant of the Department of Obstetrics and Gynecology in Bardem. He has been president of many prestigious societies like OGSB, FSSB, and BCPS, and also the former vice president of AOPOG. So I welcome Sir to be the chief guest of this session or of this webinar. Then we have very renowned person as the chairperson of this session. First is Professor Yusuf Latif Khan. He's a professor of Obs and Gynae in Rashid Latif Medical College. He's a founder member of the Society for Gynecological Endoscopy. He's the scientific secretary for IVF Society of Pakistan and the vice president of SAFO. I welcome Professor Yusuf Latif Khan. And along with him, there's another very eminent person as the chairperson of this session. He's Professor Farhana Dewan. He's the Secretary General of SAFO, President OGSB, Professor and former head of Ibn Sina Medical College. And she has been as the national coordinator of many like FIGO LDI project, FIGO PPH bundle, and FIGO PPIOD project. And currently, she is the Secretary General of Bangladesh Chapter Justosis. So I welcome both the chairperson and the chief guest. Now I give my microphone to Professor Rashida Begum. She is the chairperson of the Reproductive Endocrinology Subcommittee of SAFOG and the chief consultant Infertility Care and Research Center Limited and Secretary General of FSSB. And she's also the chairperson of the Reproductive Endocrinology Subcommittee of OGSB. I hand over the microphone to Professor Rashida Begum for her welcome address. Madam.
Thank you, Sabina. Now, respected chief guest, chairperson, audience, assalamu alaikum and good evening. Endometriosis is the most discussed topic as it is horrible, particularly when associated with infertility. I told it as horrible because nowadays I'm getting the patients and I feel that I am examining and patient sitting in front of me is the toughest question of the examinations. So I cannot understand what to do and how to do to give her a baby. And this happens due to repeated surgery, due to incomplete surgery, inappropriate medical treatment whenever it is needed, or delayed starting of appropriate treatment like IVF and so on. So today, the learned speaker and panelists will discuss about the fertility preserving management and fertility improving management of endometriosis. Dear audience, you all are welcome to today's webinar, Endometriosis and Infertility. Enjoy the discussion.
Thank you, madam. Thank you for your very nice welcome address. Now we'll start the first part of this webinar, which is the keynote speeches. We have today very eminent keynote speakers whom most of you know, and I think all of us know, and they do not need an introduction. First of all, Professor Narendra Malhotra, he is the Managing Director of Global Rainbow Healthcare, Director of ART Rainbow IVF. He is the President of INSARG, Vice President of SAFOG and WPM. He has been past president of many very prestigious societies, and he is also the Director of Ian Donald School of Ultrasonography. Now I request Professor Narendra Malhotra to be the first keynote speaker of this webinar. Sir.
Can you allow me share screen?
Yes, sir. I'm stopping my slide share.
Very good evening to all of you. It's indeed a pleasure to be connected with SAFOG, though we would love to have such meetings physically, but I think it is better as it is. Can you see my slides?
Yes. Yes.
Full screen and moving.
Yes, we can see.
But it's not the
So-
full screen.
It will come like it's not coming like a single
Sir,
slide.
it's coming partially.
Now is it coming full screen?
Not showing yet.
No, sir.
Someone has got two devices on. So fertility preserving, is it
Sir,
full?
can you? No, sir. You need to go to the slide share, I think.
Yeah.
Yeah. Yeah, now it's full screen.
Yeah.
Okay,
Fine. So fertility preserving management of endometriosis. You see, this girl is a famous painting.
belki böyle denemeyecek. O bana o curricular verildi. Buradan. Já vou dormir. Fui pra Xana. Uma velhinha, pequenininho.
What happened? I think his computer just hanged. We are waiting for Dr. Narendra Malhotra to join again. I think he is starting to join again.
জয়া স্যারের কি দুইটা ডিভাইস নাকি দেখো তো?
Dr.
Okay.
Malhotra,
না, টিএচওতি স্যারকে দুইবার দুটো স্ক্রিনে দেখছি আমি।
আচ্ছা ঠিক আছে আমি দেখছি।
একটা অফ করে দাও, কথা বলার সময় শব্দ হবে।
Unmute, sir, please.
No, that's fine, sir. Message ka.
Okay, it's okay now?
Yes, sir.
Yeah, okay.
Yes.
Yes.
I'm sorry, it's something wrong here.
Now it's coming fine.
Yeah, just a sec. Otherwise, I'll be known as Rashida Begum. So, fertility preserving management of endometriosis. That's what this is, a famous painting of a girl, teenage girl who's in agony of endometriosis. And this is what happens with the girls, and we don't understand what is going wrong sometimes. So when we look at the problem of endometriosis, see how many problems it causes. 33% of these girls were told that the problem is in their head, and there is nothing wrong with it. 20% of the general public have never heard of endometriosis, and it takes 7 years to get a diagnosis in the developed countries like America or United Kingdoms. So that is the delay, and there are 176 million women suffering from endometriosis, and 56% of these land up with their general practitioners and are in a confusion what is wrong. So what happens to these girls is they come with dysmenorrhea, and later on when they get married, dyspareunia, infertility, chronic pelvic pain. It affects 1 out of 10 women in the reproductive age group. And even in adolescent, the chronic pelvic pain, and with adolescent, endometriosis is seen as 25%. So 25% of these adolescent girls, which you see in the red, of all suffering, will be suffering from endometriosis. So let's understand what it is first, and then try to understand how we'll preserve her fertility. It's an inflammatory condition where the endometrial tissue is lining of the uterus grows outside. And this tissue is similar to the endometrium in the uterus. And 1 in 10, as we told you, the presence of tissue outside the uterus, which is similar to the endometrium, has an invasive but a non-neoplastic pattern. Hence, we sometimes call it as a benign cancer. Every woman has retrograde menstruation, and the menstrual debris reaches the peritoneal cavity via the patent tubes every month. But why some others develop this enigmatic disease called endometriosis is a different chapter and a different presentation to be discussed, because a lot of factors of immunologically and all. Once the symptoms start, especially in the younger girl, she will bear the symptoms for almost 1 year till she starts troubling her parents to take her to a doctor. So the first consultation is delayed by 1 year. And then that general practitioner doctor or the general gynecologist will, for the next 6 years, start giving her painkillers, OCPs, and it is only after the 7th year that she comes for a specialist referral and for a diagnosis that this is actually endometriosis. Now, this delayed diagnosis affects the quality of life, yes, but affects the future fertility of this girl. So how do we treat this? Now, to treat it, it should be integrated by combining and individualizing accordingly. We are worried about the symptoms, the location, the desire for pregnancy, if it's infertile, the age of the patient, adolescent, reproductive, perimenopausal, medication side effects if you're going to give her, what are the surgery and what is the cost. When we look at teenage endometriosis, the presence of endometriosis in a young girl seems like this Mona Lisa smile. You don't know whether she has pain or she's smiling because of happiness or pain. So probably she's trying to hide her endometriosis pain. That's what this painting tells us. It was considered a disease of over 20 years, but now we are seeing the higher incidence in teenagers, even reported before menarche, and reported that adolescents with endometriosis have uterine contractions. That is why the severe spasmodic dysmenorrhea is there. And because these contractions are high in frequency, amplitude, and basal pressure tone. In adolescent, advanced stage, this paper is very interesting to read. Advanced stages of endometriosis seen in young women. And it says that you still see advanced disease is not uncommon. And you're going to see a lot of ovarian endometriomas in this, and also extraperitoneal. So these girls will have peritoneal endometriosis, ovarian endometrioma, deep infiltrating endometriosis, and severe endometriosis seen in 32% of girls suffering with endometriosis. So before we go for any treatment, we must assess the ovarian reserve of these girls and then plan what we're going to do. So previously FSH was being used. Today we do it with antral follicle count and anti-Mullerian hormone, which is not dependent on any OCPs or menstrual cycle. And the mean concentration of AMH is seen to be reduced in girls, women suffering from endometriosis. Then we come to the ovarian endometrioma in girls. When you see ovarian endometrioma girl, the therapy must be individualized, and the obstetrician, the gynecologist should consider the patient's choice, the future need of contraception, whether she's going to get married soon, the contraindication to the hormonal therapy, she might not agree to take any contraceptive pills, the potential side effects, and we have to counsel all the options to the parents and to these girls about their future fertility, which we usually don't do and start giving them drugs. The three specific aims to adolescent endometriosis is you try to control her symptoms so she live life. You prevent the further progression of disease so it is not damaged, cause damage to the ovarian reserve, and hence we will try to preserve her fertility. So first thing is we need to do a diagnosis. So in adolescent, the clinician should take a careful history to identify the possible risk factors such as a positive family history, obstructive genital malformations like bicornuate uterus, septate uterus, early menarche, short menstrual cycle, the strong recommendation by the RCOG of taking a good family history. Then clinicians will consider endometriosis in young women if she has cyclically being absent from school, or with the use of OCPs, the dysmenorrhea is not getting corrected. And they may have chronic pain, they may have dysmenorrhea, dyspsia, dysuria, and of course not dyspareunia if they are sexually active. So there are some recommendations. If transvaginal ultrasound is possible, do that. Otherwise, transrectal or abdominal ultrasound to see for ovarian lesions. If this is not possible, then an MRI. So there's a very strong recommendation of doing a very, very good ultrasound. The serum biomarker C125 is not recommended for diagnosis or ruling out endometriosis. So very strong recommendation of not doing a CA125 in these girls for, or if you do it, it is only going to be for the monitoring of treatment. Then in adolescents, suspected endometriosis where the imaging is negative, then the medical treatment for pain, NSAIDs, hormonal contraception will also not work. And maybe you'll need a diagnostic laparoscopy to actually find out what is wrong. Now, if laparoscopy is performed, the clinician should consider taking biopsies to confirm the disease histologically. Although a negative histology does not rule out the disease. Again, there's a strong recommendation for doing laparoscopy like this. Then, if possible, LNG IUC, intrauterine system is best if she has adenomyosis or endometriosis associated severe dysmenorrhea. Now, for adolescent and unmarried girls, this may not be possible and may not be the first or the choice of treatment. So we might have to put them on oral treatment. Now, adolescent girl laparoscopically confirmed endometriosis associated pain, then hormonal contraceptive, progesterone therapy failed, then the clinician may consider prescribing GnRH agonists up to 1 year, which are effective and safe, and you'll have to add back therapy so that she doesn't go in for estrogen deficiency and bone mineral loss. The clinician also will consider surgical removal of endometriomas, endometriotic lesions related to symptoms, depending on the size of the endometriomas and the severity of the pain. In adolescent, clinician also should consider post-operative hormonal therapy that to suppress. So it's sandwich therapy, hormone, surgery, hormone. So what are the changes which have occurred with the new guidelines which we have from ESHRE? Now, this is the guidelines of 2022. We had it in 14, 18, and then they are revised. So they revised something about diagnosis, and laparoscopy is no longer the gold standard for diagnosis. The treatment of associated pain, GnRH antagonist treatment support they use as a second line treatment. Treatment of infertility management, I'm not going to go for that. Recurrence, let's see about adolescent. Now, this topic was not included in the 2014 guideline, but in this 2022 guidelines, it's been extensively covered on what the fertility preservation is. And this fertility preservation treatment for medical treatment could be fertility preservation. For infertility later on, they will need treatment by ovulation induction IUI or ART. So what are we going to use for suppression of this disease? Follicle preservation suppression. We can use combined OCPs or oral progesterones, the Dynogest, as the first line of treatment to induce hypoestrogenic state and antagonize the estrogen action on it. Now, danazol was being used previously, but I don't think danazol should be used in young girls because the correct dose is 800 at 800 or high doses, and for a prolonged treatment of 6 months, it can cause hoarseness of voice. And we don't want the girls to have hoarseness of voice because that's a permanent hoarseness. So danazol is out of the treatment. GnRH agonist can be the second line. For pain management, low dose danazol can be tried for some time, but it doesn't work if it is not given in the right dose. So pain management, medical treatment is generally successful. Surgical management also has demonstrated that there is a reduced pain score. The efficacy of the combination of therapies still has to be documented. And medical treatment can be used as what we call as follicle preservation or fertility preservation. So treatment of pain, NSAIDs, OCPs, androgenic agents like danazol, progestogens like Dynogest, GnRH analogs, depot preparation, antiprogesterones, and levonorgestrel IUCDs if preferable. Now, where to do surgical treatment if this girl is not getting relief and you still want to do a fertility preservation? So fertility preservation for a surgery, the surgery has to be done by an experienced person. Minimum damage, try to strip only or save the cortex as we're trying to do here. This is one of our old videos, and it is recommended only if it is more than 4 centimeters and she is not getting relief by medical symptoms. Dynogest, of course, is now the first line of treatment, and when given, it will cause hypoestrogenic state, hypergestenic, local endocrine environment, and that will suppress the disease and may cause amenorrhea or may cause scanty periods, and there is a slight bit problem with intramenstrual bleeding. What are the drugs which can be used? GnRH anta, OCPs, progestogens, antagonists, PERMs, and zinc. Now, these are divided into AIs, anti-androgenic, beta ligands, and statins. And that is some of the newer drugs are coming in as anti-angiogenic drugs and all. Where surgery has to be done, active management of small cysts may potentially prevent follicle. And you see in this video that we are trying to enucleate only the cyst and trying to save all the cortex, not using cautery at all. And that is how we're going to try and do. So here is where expertise of the surgeon is required. So not everyone should attempt endometriosis surgery unless you are fairly advanced in doing advanced laparoscopic surgery, because sometimes removal of DI, deep infiltrating endometriosis, rectal endometriosis, nodules can be very, very difficult and needs a very skilled surgeon to do it. Now, here is the SHA guide which have latestly come out, and the impact of these new guidelines on the general physical well-being of the community as a whole. So these guidelines, if they are followed, they will rationally change the whole scenario of endometriosis, because surgery goes off as the diagnostic and 3 centimeters removal before in IVF is not recommended. But what is to be done is that AMH has to be done before you do surgery and after you do surgery. So endometriomas is a cystic lesion of the ovary originating from the endometrial glands. And usually it is the endometrial gland which sits on the ovary and it invaginates in. And so it takes a part of the cortex in. So it will decrease the ovarian reserve by damaging that part of the cortex. And that's why the ovarian reserve estimation by counting the follicle, antral follicle count, and by doing color Doppler volume studies all are required. So ovarian reserve reflects the reproductive potential of that girl, and endometrioma is going to damage this, and that's how we're going to try to do. So if there are big endometriomas like this, or big cyst with hardly or a very small amount of normal ovarian tissue here, now this, if the girl was married and come for IVF, we would first do an aspirate, take out all the follicles, stimulate her, and then go in for surgery. Because surgery is going to decrease the ovarian reserve. So let's see what it can do. So antral follicle count, endometriomas, and then surgical treatment will decline it. Anti-Mullerian hormone already show a decreased level with endometriomas. And with surgical treatment will be a further decrease. Number of oocytes with endometriomas, lesser number of oocytes. And with surgical treatment, still may have even more lesser U. So the present of endometriomas are going to be damaging. Now let's come to the real fertility preservation, and that is the oocyte cryopreservation. Option should be discussed with all these young girls. So the indication is restricted to those girls who have endometriomas at a very young age and who are not planning marriage or are going to delay their fertility. So pros and cons of fertility preservation has to be discussed very well. Oocyte, or if they are married, embryo preservation. We can do ovarian tissue preservation, injection of PRP and stem cells into the ovary, artificial ovaries and in vitro cultures. All have these, some are experimental and all have their advantage in front. So the fertility preservation can be divided into what, why, and when. So the what is that you are trying to protect the eggs here because the ovarian reserve is decreasing. Why is because this medical disease called endometriosis is damaging the reproductive system and going to have a poor reproductive outcome in these girls later on. Usually done for cancers, but the medical disease like this, very big fibroids, very compromised big tumors, all that you can do. Of course, there's some social freezing indications also. Who needs it? A lot of people need it, but here is an indication of endometriosis, women suffering from endometriosis who are not wanting fertility and who are adolescent and want to preserve the fertility needed the maximum. So it is going to be a patient-centric care shared decision where you discuss with the patient, discuss with the parents, discuss with the guardians, and all the pros and cons. Now, when we look at the papers published in this, is ovarian reserve reduction following endometriotic cystectomy. So yes, it is going to reduce. Hence, they have to be offered some sort of preservation. And this preservation is for the risk of premature ovarian failure, which this disease endometriosis can cause. And this would be considered fairly high because of disease in many young women. So these are the non-oncological regions, the endometriomas you see here, very big endometriomas. Even when we remove them surgically, only a little part of the ovary is left. And it's better that we preserve our oocytes first before doing surgery. And again, a lot of papers and data on showing the clinical outcomes of by age, vitrification, surgical excision, before oocyte vitrification, after oocyte vitrification. So the SWOT analysis of endometriosis is the strength, weakness, opportunity, and threat of the disease. And that has to be analyzed before we offer them anything. So at the time of first diagnosis of endometriosis, management must be feigned completely throughout for the patient's life. Recurrence and all should be discussed. Impact on the reproductive life should be discussed, and fertility preservation should be offered right on the first. And here is a supplement of the FIGO journal, a special position statement on fertility preservation, which covers a lot, everything. And I would recommend that all of you go through this special edition. So we're going to do oocyte preservation. How do we do oocyte preservation? We stimulate, take out the oocytes, and vitrify them. And vitrified oocytes gives you a fairly good yield when you thaw them and fairly good pregnancy rates. So oocyte preservation for endometriosis is indicated for adolescent girls with severe endometriosis. And this is going to be done by vitrification. Then there is some modified conservative surgery can be done before you do. So if there is something like this, you could do a partial cystectomy, ablation, and then go ahead for it. So before that. There is now in our armamentarium and some papers also that you can do ultrasound guided cyst aspiration and inject sclerosing agent as we are doing here, as you can see. And we have sclerosing agents which the surgeons use for piles and varicose veins, which is safe and can be injected. And through the ultrasound, we're going to aspirate all the cysts, wash it with saline, use the home pickup needle or any 30 centimeter 17 gauge needle. And then that's the endometrioma, which you can see on the screen. And once we put the needle in, aspirate it by normal suction and wash it a couple of times by sterile saline and antibiotics. So the infection, once it is aspirated, escarole, which is prepared like this, where you take it in 2 syringes on a 3-way cork and make a foam out of it, and that foam is finally injected. So that the foam is being injected. So this could be a treatment offered. Of course, sterile, it should be a very sterile thing because there is always a risk of ovarian abscess and all, and and should be properly antibiotic covered. What are the emerging treatments? Ovarian rejuvenation. So injection of PRP or stem cells, autologous stem cells in the ovary. And by the speaker after me, Jay Mehta, is one of the pioneers in the field of reproductive regenerative medicine, and he's done a fair number of cases of stem cell injections in the ovary, and I'm sure he's going to. So when there is a ovarian failure or insufficiency due to endometriosis or any other cause, this is the algorithm which we are going to follow. And ovarian PRP and stem cells now come into this algorithm as fertility preservation. So how do we do it? We'll try to show you in the video how we do it. You take the germline from the bone marrow, or you will now get prepared stem cell injections and mix them with PRP. And we're going to try to inject them into the cortex. So PRP is prepared fresh and then stem cells are taken. We in India get from one of the REI companies prepared stem cells for rejuvenation, or you can aspirate bone marrow from the iliac crest, wash them because we are not allowed to culture and change the cell line. So we have to inject like. So this is how we used to do by laparoscopically before. Hold the ovary. This is one of our old videos. Hold the ovary and just try to do it one puncture, because if we do it at many punctures, then it is going to leak out from the others. Just under this. Now this is easy and simple to do. But what we have started doing now is that we have started doing it with the transvaginal ultrasound. Now, with transvaginal ultrasound, we are using the 22 gauge needle, very thin needle, because these are very small ovaries and they're very mobile. They're usually not fixed. And when I push it with a thicker needle, rather than piercing, the needle will push the ovary out. So I'm going to try to do it with a 20 to see how small that ovary is. Luckily, it is right next to the probe. And then we will prepare the PRP or the stem cell and go under the cortex here. Again, at one place only, because if you make multiple holes, then you're going to try, then it's going to leak out, and do it on the other side also. So that is what we have started doing now with from laparoscopy, switched it over to ultrasound guided. So stem cells in human ovary derived from basis of in vitro activation. So in vitro activation of these can be done, and those stem cells can also be injected. Now we have the first paper from India and the first baby born from India from Pune, Dr. Sunita Tendulkar, injecting autologous stem cells and PRP in the ovary, and this was published in the Alzheimer's Journal. Then the ovarian tissue if the ovarian tissue is very less and it is gone, usually this is for cancer patients, you can take out the ovary, and the whole ovary cannot be reimplanted, which is a little difficult to catch because they don't catch the vascularity. But then you can make slices like here, that's the ovary, and then the slices can be made. And as you can see, this is our son, Dr. Keshav. And then the slices are put on these needles on a tube and they are frozen. Now, these slices can later be reimplanted in the ovarian fossa, in the broad ligament, and they'll generate. Or now they're being tried, we're trying to put them in the forearm. And you see the ovary in the forearm. And when you stimulate, this ovary will get stimulated. So oocyte retrieval would be very, very easy, right? Just under the skin. So that could be possible. If we put the whole ovary back in, the revascularization is difficult and there might be ischemic injury, and that does not take over, and the follicles may get damaged in that. So that I have accidentally done a whole ovarian transplant in a very severe case of PPH of placenta accreta. We had to do a very emergency hysterectomy, which accidentally we took out. We did a complete, we took out the ovaries also. And then once we realized, we put those ovaries back into the vaginal vault, which we had stitched after roofing. And she did survive till menopause with the normal estrogen. So that was my first case, done some 12, 13 years back in a small setup in a very accidental way. So the fertility preservation will be accumulation of oocytes, ovarian autotransplant, and if they're pregnant, acute. Now then, if this doesn't work, later on these people can opt for artificial gametes. Now that is a future of reproduction, that artificial gametes will be made. First babies, animals from artificial gametes have been born, ovarian and cystic. So ladies and gentlemen, the potential breakthrough in fertility preservation for endometriosis is medical. Try that. Aspirate the cyst and inject sclerosing agent, and then do oocyte preservation. Oocyte preservation first and then surgery, or partial surgery and then oocyte preservation and then complete surgery. Cryopreservation of embryos if she is getting married, if she is married. Ovarian tissue cryopreservation if the ovary is very damaged and you get a very less amount of tissue, and PRP and stem cell injection, and in the future, maybe artificial gametes. So development of fertility preservation is now on and probably being offered by any ART IVF centers for infertility. There is some primary prevention for endometriosis also. There is no direct evidence of lifestyle, diet, smoking, alcohol intake, physical activities, hormonal contraceptives, and there are some nutraceuticals made only for ovarian rejuvenation with CoQ10 and omega-3 and all that. And that we need lots and lots of studies to say whether this is going to work or not. So ladies and gentlemen, to conclude, endometriosis is an enigmatic disease. It's an epiphenomena. It's like a benign cancer. Fertility preservation option must be kept in mind with all adolescent girl and young patients who desire fertility in the later of life. I thank you very much, bring you greetings from all these women who've had fertility preservation all over the world, and some of us with us. Thank you very much for giving me this opportunity to share some of my views.
Thank you, sir. Thank you. It was a brilliant lecture as usual. You covered everything about endometriosis, and actually the future of endometriosis is in fertility preservation, as you rightly said so. So now I request Professor Farhana Dewan to say a few words on Professor Malhotra's brilliant presentation.
Thank you, Dr. Tanzim. Respected delegates present in this webinar, good evening to all of you. Because of constraint of time, I'm not addressing anyone specifically. I think it was really a very brilliant presentation from Sir, and it was an eye-opener sort of thing for all of us. And I would like to emphasize one or two points which I thought that are important. Firstly, he has very rightly mentioned that how endometriosis takes, he mentioned about the endometriosis in young girls, that they wait for 1 year for the symptoms to start, then is delayed for 6 years the treatment, and 7th year they go to a specialist. That is the initial delay for these girls. It's very important. And regarding the treatment, he also mentioned about a type of endometriosis in adolescent girl. Endometriosis, what are the specific aims when we go for treatment of these girls? And then he went on to give emphasis on the, for diagnosis, he has given emphasis on the imaging. That is, maybe transvaginal not possible, go for transrectal ultrasound, do the MRI. And specifically has mentioned that CA125 should not be done. And then he said that after that, well, there are some other options we know, like LNG IUS and also the GnRH agonist. So these will be the options. And of course, we'll have to think about the surgical removal as well when they are not treating, not responding to medical treatment. Then he talked about the sandwich therapy, hormone surgery, and hormone once again. And of course, we all know that laparoscopy is not the gold standard at present. That we all should remember. And now coming to the medical treatment, he has mentioned that combined oral contraceptive and Danagest first line, danazol and GnRH second line, but will follow that COC will be the first line combined oral contraceptive and GnRH agonist will be the second line. And then he mentioned about the pain management. And he also mentioned that how the newer drugs have come out, and expertise of the surgeon is very important. We should remember. And expert, that is very rightly, I think Dr. Jai Mehta was also here the whole day in Dhaka doing surgery in our center. And there also he was mentioning, and we all think that it is very important that the expert surgeon should be doing it, and we should be expert in advanced surgery when we do this sort of things. And of course, he mentioned about the ISHRE guideline. Then he went on to the talking about the ovarian reserve. And very importantly, he mentioned about the 3 things when treating when going for fertility preservation: what, why, and who. So what is the reason? Trying to protect the egg. Why? Fertility preservation for medical treatment. Who? The endometriotic women. So I think these things are very important. Then of course he later on went on to sclerotherapy and all that, ovarian rejuvenation and PRP and everything. So in nutshell, I would like to mention that Dr. Narendra Malhotra's presentation was really a very comprehensive one, and we have learned a lot. Thank you very much, sir, for your extensive presentation.
Thank you, Appa. Thank you for your nice comment. Now we go to our next presentation. Next presentation is by Dr. Jai Mehta. I'm trying to share the slide. Okay. He is the director of Sri IVF Clinic, but that should not be his only introduction. We all know, as Dr. Malhotra has said, he's the pioneer of the reproductive regenerative surgery, and he's very famous among young gynecologists for his amazing surgical videos on YouTube. May I now request Dr. Jai Mehta? Now I request Dr. Jai Mehta to start his deliberation.
Hi, everyone. Good evening. I'm doing this presentation from Bangladesh actually, and I'm in Dhaka right now, and it's actually my first time here. So sincere thank you to all the members of SAFOG for having me here, and many congratulations to Malhotra sir. He is a very close friend of mine, and good to see him here. Good to see even Jaideep madam here. And I'm here in order to share the experiences which we had on the hands-on training, which we did today in Dhaka. And first of all, before I start, I just want to say it was really amazing arrangements. Okay, the type of arrangements which was done by Dr. Rashida Begum and everyone else, Dr. Fahmida, and then Dr. Farhana Diwan, and everybody who met me in the morning and throughout the day. I think we operated around 8 cases. I think probably 9, but we did 7 cases with fertility preservation out of that. And there are some important things which I thought we must point out, especially because we are having an open discussion on this. And I think one of the things is, as I mentioned even in the morning, one of the things is we as gynecologists have so much fear of operating in endometriosis, especially when it is required to operate in endometriosis, right? And I think through this platform, I take this, I take this moment to tell everyone that this is something, if you have an acquired surgical skill, the answer is acquired. So that's mean basically you are going to learn it after practice and after dissecting in the correct planes through your experience. If you have this acquired surgical skills, then practically you are going to be able to do a very, very good job, especially of clearing endometriosis from wherever it deserves to be cleared. Once you go inside to do a surgery, the most important thing is to achieve a radical clearance of endometriosis. Okay. As we have discussed, we are all already aware that there is going to be a loss of ovarian cortex. There is no second question in that. I think that should not even be debated. It is going to happen that there is going to be a loss of ovarian cortex. And that is going to compromise the ovarian reserve, fertility, and AMH, all the three things. But I think in this, there is one important point. The big problem is not to treat endometriosis, which is a unilocular endometriosis. The big problem is what we encountered even today in many occasions is to treat multiseptate, multiloculated endometriosis. The problem with multiseptate and multiloculated endometriosis is no matter what you do, you are going to be remaining with very, very little functional ovarian cortex. All right. All these other sclerosing agents like alcohol and all these things are not going to work in multiloculated endometriosis. It's a very bad, disastrous complication of having an ovarian abscess. If anybody has ever seen it and treated it, it's a bad complication. Okay. In fact, today we had one of the patients, no alcohol injection was done, but we had one of the patients in whom we had bilateral teomasis. Okay. And she was somebody who was operated for endometriosis approximately 2-3 months ago. And the surgery could not be completed due to the lack of instruments at that point in time. But see, once somebody had put in a laparoscope, even that was enough to cause that much amount of pelvic inflammatory changes and causing an abscess inside both the ovaries. So I think that is a very, very, very important take home point. In fact, I really appreciated what Dr. Rashida madam discussed with me, her protocol of using sclerosing therapy in the ovary, and she tries to give an antibiotic a day before and clean up the vagina and then put in the needle. I think that's a good technique. We do something additional to that. We actually do a high vaginal swab before we post the patient for sclerotherapy in the ovary for endometriosis, but we don't do it very much because I personally don't have a very nice experience of using sclerosing agents in the ovary, and I have seen a lot of complications of people doing it. So I have certain reservations. Probably they'll go away once I start doing many more cases of that. Apart from that, I also think two more important things. Okay, many times in endometriosis, we are scared to do the bowel dissection. Okay, and we are scared to do the bowel dissection because despite knowing for a fact that we have a nodule or we have an adhesion or we have whatever, okay, we are scared because we are worried that what if something going to happen to the ureter. So I think one must follow a protocol based approach in order to dissect the endometriosis and to do a deep dissection of endometriosis. And I hope all the delegates who attended the plenary session as well as in the operation theater today would have probably seen the stepwise approach, right? We almost always do the sigmoid mobilization first, then we go on to the sacral promontory, identify the ureters on both the sides. Then we further our dissection inside the peritoneum and lateralize the ureters. Then we go and dissect the pararectal spaces on both the sides, and this allows centralization of the bowel. And that is when we go and dissect the bowel after dissecting everything above the nodule and everything below the nodule. So basically the bowel is adherent only at a point, which is a focal point of adhesion. And usually if that is relieved, then usually the outcomes for bowel surgery and bowel endometriosis are really, really very good. And I think we saw that today. The other thing which we saw today, and I think it's a very important point, is that in so many of these occasions with endometriosis, you are going to have, especially on the right side, appendix involvement, because we had it in one case today where we saw endometriosis having an appendix involvement where we had to do an appendicectomy along with that. And in that patient, though the appendix was adherent to the fallopian tube, both the fallopian tubes were patent, okay, which was a great thing for the patient. But simultaneously, if you have a preoperative hematosalpinx which is present in the fallopian tube, the hematosalpinx is going to give you very, very poor outcomes. Okay, and usually the tubes with hematosalpinx will warrant a removal, and those tubes will have to come out, and the patient will then opt for ART. And before I conclude, I think I was given 15 minutes. So before I conclude, I want to mention that usually if the lady is young and the male factor is absent, we can start ovulation induction from the next month in these girls. Okay, which is what we discussed today as a part of our discussion. And same thing, they can opt for IVF from the next month onwards. And one need not really wait for a prolonged period of time before they opt in for any of these therapies. All right. Uh, and finally, I just hope the surgeries and all the patients are doing well, and I hope all the delegates who attended today in Dhaka at the medical center enjoyed the surgeries, and I thank you for the wonderful arrangements. And I think this is a very short trip. I'm here only for 36 hours. Maybe next time I'll be in Bangladesh for maybe 2-3 days and go some shopping. And I also want to extend a big thank you because I really wanted to visit the mosque, and I thank Rashida madam for getting people to send me to the mosque late in the night, and it was wonderful. So thank you so much, guys, and I hand over the session to the organizers. Thank you so much.
Thank you. Thank you, Joy Mehta, for visiting Bangladesh and for your brilliant surgeries that you have done today, and also about your experience here. We are going to include you also in the panel discussion to talk about different scenarios of endometriosis with infertility. So now I request Professor Yusuf Latif to say a few words on Dr. Joy Mehta's deliberation.
Dr. Tanzim, can you stop the screen share?
Oh, sure. It's already stopped, I think. It's just.
Then I have to get in.
No, Appa, it's not stop. Yeah, now.
So can I request Professor Yusuf Latif to say a few words on Dr. Joy Mehta's lecture?
Hi, how's everybody? Thank you for inviting me to be over here. I hope everyone is well. And this endometriosis, as everybody knows, is kind of a disease which is kind of worse than a cancer which anybody can get. Everybody knows that by the cancer outlet, we do understand what's going to be the outcome. But with this kind of disease, it is one of those which does not let you go, and it kind of lingers on and on till the end of your life, probably with doing that. And people, they need to kind of tend to kind of live with it as long as they possibly can. I'm sorry, kind of missed out a couple of talks of Dr. Jay because it kind of my internet was kind of fluctuating in between. But sorry about that. Just give me a second.
Dr. Tanzim, Yusuf sir also does a lot of surgeries himself as well. He can share his experience also.
While talking about this surgery of endometriosis, the first surgery is the most important one, whoever does that. And the first surgery, it has to be happen in an expert hand. And if that one is done immaculately or kind of in as close to the perfection as possible, then the outcome and the results of whatever you do later on with this is kind of makes a difference. But in my own experience, I've seen that endometriosis, every time we go in, we find something new. I have not seen kind of two cases similar to that. Dr. Malhotra was showing us different videos of this cyst and this thing. You need to be very, very careful how to preserve that ovarian part and how to peel off that cyst. There has been papers here in the they say that in the first attempt you just drain the cyst out and you give a Zoladex for 3 months, and after 3 months then you do redo surgery and then you take out the cyst wall and this. Yes, it is all possible, but in our part of the world, the cost goes up. And you can't explain to the patient that they have to go surgery once now and then maybe have a Zoladex, which has a certain amount of cost. In Pakistan, it is something like 10,000 rupees a month. So it's about another 30,000 rupees added to their cost, and then they have to another go for another surgery. And for endometriosis, I think I believe that in these times, anywhere in the world, doing an endometriosis in an open surgery is very close to a criminal part. The way you can do it endoscopically or laparoscopically, it gives you a lot of advantages, wonders, and the benefit all goes to the patient. So anybody who wants to get, and it's a specialized field, and anybody who is interested, then they have to be really properly trained for this pelvic surgery, even going up to the dissection of ureters, and then even bladder endometriosis, and so on. And then in the end, I think the best benefit would be from the patient unequal. And we do end up following up these patients with giving them either some menopause for keeping them 3 months, or giving them going for them IVF earlier, because we do know there's a 25% of recurrence rate within next 2 or 3 years time. So we have that window period for fertility part, in which those patients, they can be helped as much as possible. So I would like to thank the SAFOG, and it's good to see my good old friends from Bangladesh, India, and it's good to see Dr. T. Chaudhary Sahab, sir, Assalamu alaikum, and everyone here. And in good, and as Dr. Malhotra was saying, that we had a withdrawal of all these, not meeting all these friends, and hopefully we can all meet up together physically and have some more fun. Thank you very much for inviting me over, and it's a pleasure to be over. Thank you very much.
Thank you very much. Thank you, sir. Now we come to the second part of the session, which is the scenario discussion. Everybody is actually welcome to share their experience. We'll start with the discussants, and then the next, all of the, I think, speakers can also include. So today we have the 4 discussants with us. Professor Shakib Siddiq, he is the CEO at Mid City Hospital. He actually worked in the Institute of Medical Science, served Government of Punjab for more than 30 years in the health department. Next one is Professor Jaideep Malhotra, Managing Director, ART Rainbow IVF, President, South Asian Federation of Menopause Society, and she has been past president for a lot of prestigious societies like ISAR, FOXY, Aspire, and IMS. Professor Rubina Sohail, past president, SAFOG, vice president, Menopause Society of Pakistan, member of the Society of Obstetrician and Gynecologists of Pakistan, and member of IVF Society of Pakistan. And lastly, but not the least, Professor Hemant Saranayakar, Emeritus Professor in Obstetrics and Gynecology, University of Colombo, board member, Asian Society of Endometriosis and Adenomyosis, and president of the Endometriosis Society of Sri Lanka. So let us start with our scenarios now. Just give me 2 seconds. I have to stop this. The old one is coming. So let us start with the new one. So today we are going to talk about the scenarios which involve both endometriosis and infertility. This is actually, can you see the slide, please? Can you see it?
Yeah, but just go to the slide share, please.
Yeah, I'm trying.
I think we need to make it a full screen.
Yeah. Is it
Full screen? No, it's not full screen yet. Just go to the right lower button, the cup shape button. Just click it here. In the below.
Okay, let us start with the scenario first, then I'll go to the full screen. It's not happening now. So let us start with a 32-year-old woman. She already has a child. She presents with severe dysmenorrhea and dyspareunia and secondary subfertility. On ultrasound, there's a chocolate cyst about 4 to 5 centimeter in size. A gynecologist advised her for laparoscopy, but she doesn't want to go through the laparoscopy. What are the other options she has, and what should be the plan for her treatment? Let us start with the discussion with Dr. Joydeep Malhotra. Dr. Joydeep Malhotra, can you see me and see the scenario?
Yeah, hi, Tanzim. Yes, actually, I'm traveling in the car. I hope you all are able to hear.
Yeah, you're clear.
So this is a normal, typical scenario. The best part, which I would say, is that only one ovary is involved, but the severe dysmenorrhea and dyspareunia actually maybe there will be, possibility of deep uh, infiltrating endometriosis and other areas which may be involved. So we need to really do first a good scan or an MRI and do her AMH, which is very, very important because she's 32 years old. And our decisions will basically be made on two important things. One is her symptoms and how severe they are. Second important thing is her AMH. And the third is how keen she is to, preserve her fertility and further reproduction, which is again very important in most of the scenarios. So these three things have to be kept in mind in decision making. If her AMH is good, I would say, that we probably may give her some medical management for 2 or 3 months because that's something which is going to probably decrease her symptoms. And if the AMH is not really good, I would really look into oocyte and embryo preservation first, then do her surgery, relieve her of her symptoms, and then maybe go ahead and do an embryo transfer once the pelvis is clean. Now, most of my decisions would actually change after counseling and talking to the patient, the husband, and looking at their financial status, looking at how if they're really wanting to avoid the surgery. I think it's a good idea for us to go ahead and do IVF. I'm sure there will be people in the audience who might go ahead and try ovulation induction in these cases. I've had quite a few cases in my 25 or 30 years of practice who have actually had pregnancies with one or unilateral endometriosis. But in this particular case, because of severe dysmenorrhea and dyspareunia, these are the two important symptoms. And whenever there are symptoms, surgery is the first indication, which I understand, because we need to really relieve her of her pain and have a quality life, and then think about her fertility, and which is quite very much possible, keeping in mind that her other ovary is normal.
Okay, thank you, madam. So your first preference would be, I think, going for IVF, but she
No,
can.
relieving her of her symptoms first, and that is going to be surgery. But the kind of surgery which needs to be done and whether fertility preservation is required or not will all depend upon her ovarian reserve status. So I would definitely do her AMH first and MRI and good counseling, and then decide.
Okay, thank you, madam. So can I go to Professor Rubina Sohel? Do you agree with Dr. Malhotra? Do you agree with Professor Joydeep Malhotra that she should actually go for surgery first to relieve her symptoms, then go for fertility treatment?
Thank you very much for the question. So I do partially agree with her. I would just like to put it a little bit differently. I think these women need an empathetic approach. And it is very important to explain to the woman that when she's 32 years of age, she's going on to a situation where the natural fertility will also start declining very soon. So I think this is one thing that she needs to understand. The second thing is that in endometriosis, only one ultrasound report mentioning a 4 into 5 centimeter cyst mostly does not tell the whole picture. So in
Yes.
order to understand the whole picture, we need to evaluate her further as Dr. Jaideep said, that an AMH and an MRI and a detailed ultrasound to understand the deep-seated endometriosis is important. And I think it is also important to tell the patient that in her particular situation, because there are two things. She's looking for fertility and she's looking for a relief of her symptoms. So it is pretty important that we need to act quickly, because if we let her waste this time and we dilly-dally, then there is a possibility that the disease might extend further and she won't have a chance to reproduce again. So I would go for laparoscopic surgery and a laparoscopic evaluation. And following the laparoscopic evaluation, I will discuss with her and plan treatment. I do understand that you said initially that she's reluctant for surgery. So I would try to understand her reasons for the reluctance for surgery, because in most of the patients with endometriosis, the patients believe that laparoscopic surgery is going to do more damage than good. And
Yeah.
a falling AMH is one of the reasons that they believe, which is not totally untrue. And that is why in endometriosis and infertility, it is believed that the first surgery is the most important surgery. So the person who is going to be doing the surgery has to be experienced, has to be trained, and has to be skillful, so that we gain the maximum benefit out of one surgery rather than going again and again and repeating the surgery. So yes, agree with Jeff, but I think that we need to change the approach a little bit and talk to the couple and try to explain to them to the situation, taking care of the financial status and their psychological well-being.
Madam, do you think there's any role of hormonal suppression in this patient?
I actually don't think so.
Okay.
I actually don't think so, because I feel that a hormonal treatment basically wastes a lot of time. And most of the time you find that did not actually result in suppression, and it is not going to help improve the fertility. So what is the point?
Okay.
I really don't.
Thank you, madam.
Tanzim,
Yes.
in case like supposing if she is really not ready for surgery, 2 or 3 months of agonist therapy can be given in such patients,
Okay.
and it gives you time, and that's especially if the AMH is okay, because here I am believing that the other ovary is normal.
Okay. As it is,
So
you
it-
want
so
you
it
want
is
to go for, you want to
it
go
is
for,
okay
yeah.
Hello.
because that will reduce.
Yes, sir. You want to say something? Dr.
Yeah,
Shakib.
I'm sorry, I had to go somewhere. May I say a few words before I leave?
Yeah.
May I take this opportunity to congratulate Professor Rashida Begum for having this, she's chairperson and running a very successful IVF center there. May I remind that I think she's one of the pioneer IVF center in Bangladesh. So I and my embryologist, Dr. Nigat, came to Bangladesh to establish their IVF center about 20 years ago. And hello and assalamu alaikum, Professor T.A. Chaudhary. Because when he, about 30 years ago, maybe 25 years ago, when he came to Lahore, he visited my center and I showed him the egg retrieval, transvaginal egg retrieval. So regarding this symposium, the endometriosis and infertility, I'm glad that Professor Malhotra said that if you are planning IVF and the person is and the lady is suffering from endometrioma, first do egg retrieval and then go for the surgery, because after the surgery, definitely ovarian reserve will decrease. So that was a Then regarding the pelvic abscess, I have seen many cases. Many of the radiologists here in Pakistan, they are very fond of doing cyst aspiration, simple cyst as well as in the endometriomas. In simple cyst, there is usually no problem, but leads you inject the bacteria and it leads to infection, inflammation, and abscess formation. So one should be very careful while aspiration the endometriomas. Thank you very much. And thank you for
Sir,
having me.
can I give you another scenario before you leave?
Okay, sure.
Okay.
Sure.
So this is actually a 25-year-old woman with a history of endometrioma. She actually was treated with medical.
I can't see this. I can't see this slide here.
Tanzim, you change your slide.
I have changed it, Appa. It's not showing?
It's not showing. Okay,
It's coming
that's
scenario 3, 32 years.
yeah. Okay,
Okay,
go ahead. Go ahead. I'm listening.
Okay, let me show first.
No problem.
Let me show you, sir. Otherwise, it's difficult. Is it showing?
Yeah, sure.
Now it's showing.
25.
Okay.
Yeah,
So
yeah.
she's a 25-year-old woman who had a history of endometrioma, which was treated by medical treatment 2 years back. All the documents are lost. We do not know what was the size was, but that was when she was unmarried. Now she's married. She is suffering from dyspareunia. Her HMH is quite low, 1.1, considering her age, AFC 3+4, and there are some nodules in the pouch of Douglas. So how can I actually treat this condition and make her fertile, because she wants an issue now, sir?
Okay.
Nodule.
Endometrioma.
25
25 years old women, endometrioma, married for 2 years. Yeah. Is married and want to issue. Yeah, if she complains of dyspareunia, I think we should relieve the pain symptom first. And because if she cannot perform the proper intercourse, then fertility is not possible. And she's quite young. And in this case, we can perform the surgery and remove the endometriosis from the pouch of Douglas. And in this case, because there is no cyst in the endometrium, in the ovary. So the problem is ovarian reserve is not there. This is my plan.
So you want to go for surgery to remove the nodules?
Yeah, surgery.
Yeah.
Because
so
she's suffering from she's suffering from dyspareunia.
yes.
To
But what
relieve the pain
about
during
fertility?
intercourse.
Do you want to go for ART immediately after surgery?
Yeah, they can go, but the lady is young and she's
Yeah.
25 years of old. If the fallopian tubes are patent, why IVF?
But her AMH is quite low. Is it alarming to you, sir?
Yeah, AMH. Yes, I agree with you that it is. If the disease is progressing, it may progress. Then I think we can perform surgery.
Okay.
And IVF. Then followed by IVF. Yes.
Okay. Professor Rashida Begum wants to add something, madam. Appa, unmute yourself.
Sorry, I did not raise my hand.
Oh, sorry.
But
Okay, so let us go to, Professor Hemant Senanayaka is with us? Has he joined?
Yes, I'm here.
Sir, do you want to say anything about this case where there's probably deeply infiltrated endometriosis?
Her image levels are quite low.
Yes.
And, I think if she has pain, that should take precedence over everything else. And here we are not talking about removing an endometrioma. Although there is mention of an endometrioma, we don't know the size, etc. But I really think with the transvaginal ultrasound, we can do much better, and we can really get a very good idea of the extent of the disease. Even in the previous case that you showed, madam, there is the report says there is a unilateral endometriosis.
Yes.
We could have got a much better idea of the severity of the disease. Because if it's just a unilateral endometrioma in the previous case, there I would say there is a place even for ovarian stimulation with clomiphene citrate or even letrozole. So
yes.
just a few cycles with that plus IUI, and there is good evidence, even in the presence of an endometrioma, that have good results.
Okay.
In this one, I mean, the main issue is that she has pain. The other is that her AMH is low. So
yes.
it's a real difficult situation. But in this situation, like it was mentioned before, if the tubes are normal, maybe we could give some chances with stimulation plus or minus IUI. But otherwise, what do we do with such a low AMH level? You might need to think about donor, etc.
Okay.
But certainly, being 25, it's fully worth the while giving some chances for immaculate conception.
Okay.
With help from us.
Tanzim?
Yes.
Yeah, I just wanted to, bring in something to everyone's notice. The first thing which I wanted to know about this patient was how long has she been married and has she really tried, conceiving, which is important. What is the residual disease, if at all, is there? Because you haven't really mentioned. Her AMH is low, but that doesn't really mean that we need to, go for donor eggs or something. I would really counsel her well. I would think about fertility preservation, and in such a case, I would go for embryo accumulation, freeze them all, and even in spite after a good counseling and her understanding, and after freezing the embryos, even if she wants to go and try for the surgery to relieve her of her pain and try naturally, it's okay. So it all depends on how your dialogue with the patient and your understanding of the patient is very, very important. So these decisions are not really straightforward, but think of it that if we waste time and if we do a surgery and we have, find some more residual disease on the ovary, her AMH is going to go down and decline because of the disease and also because of the surgery and also because of her age. When will she have her first baby and when will she have a second one? So I always feel very safe if I have, let's say about 7, 8, 10 embryos stored. And after that, if they want to try for some time naturally, it's fine. Otherwise, IVF, complete their family and then, take care of their disease for long-term basis.
Okay. Okay. Thank you, madam. Thank you. Now let us come to
you go ahead.
Okay. The next scenario is she is actually a 28-year-old woman, married for 5 years. She is trying to conceive. She already had a laparoscopy for endometrioma about 2 years back. That was a unilateral endometrioma. Then she had repeated cycles of IUI with gonadotropin. AMH is now 0.65, AFC 2+3. There's, recently, again, bilateral endometrioma, about a small one on the left side and a slightly bigger on the right side. So what do you want to do? Do you want to go straight to IVF or do you want to do anything else as a preparation for IVF? And what should be the preferred protocol for IVF for this patient? Can I start with Dr. Narendra Malhotra?
To take this question, he is driving actually.
Oh, okay, okay.
So I would say now let us understand what happened previous case. If we had not done what we have done in that case, if we follow that case up, exactly this is what is going to happen. And once there is a recurrence of the disease with stimulations and IUI, the AMH has fallen further. Now, what kind of a hope are we able to give to the patient? So I firmly believe that we should preserve the fertility. Even in an adolescent, I would take a cortical, tissue and freeze it at the time of the surgery. So this is something which we really need to. Now, if you ask me, I would have done IVF a long time back in this patient, without wasting any time on IUIs. But again, it all depends on our dialogue with the patient, because there are times when the patient is totally reluctant in trying IVF. They have a total mental block for IVF. Now, those are the patients where if we are doing some stimulation, it has to be very cautiously done so that the moment you see the recurrence of the disease, you have to stop and the suppression has to be put into place, and then a further attempt to make them understand the implications of a recurrent disease have to be put into place.
Okay. So, Dr. Rashid, do you want to add, Madam? Rashid Appa, do you want to add something?
Actually, I am with Joydeep Malhotra's comment. In previous case also, both these cases, If there's pain, we have to give some medication. Recently, Ilagox is very excellent drug for controlling pain. So after medication subsiding the symptoms, then we should go for IVF. Or actually, dialogue is very important. In my situation, I discuss about the economic condition. If patients are capable to do ART, then definitely for these two cases, ART is must for preservation of embryos. Then we can for surgery for relieving pain, completely removing the endometrial focus. And after that, after saving the embryos, after that, if tubes can be found fine, then they can try for spontaneous pregnancy. If occurs, or we will transfer the embryos. So in this case and previous case, for both these cases, if patients are capable, then REI is the first choice. But if economically they are not able to do the procedure, then we are bound to do surgery first, and then they will try for naturally. Because in our situation, some patients are really not capable to do RT. For them, we have to go for surgery. But if they're capable to do RT is the first choice.
Thank you, Madam. To Professor Rubina Sohel. Madam, you want to add something?
Thank you very much. I just want to add two things. The first thing that I want the audience to understand is that the first year after laparoscopic surgery is the best time to get pregnant. And if we waste that, we have a study, which was published this year, and in the International Journal of OBGYN, exactly the same. So I think for the younger people who are attending this webinar, the message has to go across. First year after laparoscopic surgery is an optimal time for the responsibility. So we will ensure that. The second point is regarding this scenario. Actually, affordability and what is the right treatment that. So obviously, we do have to consider whether the patient can afford it or not. But for this particular case and the last one, I would personally think that ART is the treatment of choice and IUI is not a suitable option for her. Because the more you wait for these kind of women, the lesser the chances that they're going to become pregnant. So with this AMH and the one even previously, I think action should be quickly taken and the patient need to be counseled in detail of the fact that she needs to undergo an IVF treatment. The third point is that if in cases of deep infiltrating endometriosis, you go for surgery first, there is a possibility that you are going to worsen the AMH further. So that is why fertility preservation before you actually go on to lap surgery would be recommended. These are my takes on this particular case. Thank you.
Joya,
Yes.
one last word I want to add before I leave. It's very important in the first dialogue with the patient that we, tell her the history of the disease, how it's going to progress, and what kind of an impact conservative management or surgical management will have on their future fertility and also on the progress of the disease. And this is really, really very, very important. Second thing is that even if they are not financially, I would say, okay, it is important, and I think it is the onus lies on us to at least explain to them what will happen if there is a recurrence of the disease. And I have seen most of the times the patients, understand, because anyway they're going to spend 2-3 times on the surgery. I've seen enough number of cases where a second or a third surgery is done and the reserve is totally gone. In our clinic, our protocol is depending upon the age. If she is in a reproductive age group, after the first surgery, I will put her on, agonist, long-acting agonist for at least 2 months. And with the third injection, we have already counseled her, and we'll go in for an ART cycle, and maximum results come with this protocol in our clinic.
Okay, thank you, madam. Thank you very much. Actually, this discussion can go on all night, but I think we should come to the last scenario. This is a scenario where a 40-year-old, this is actually a 40-year-old woman. She's nulliparous. She's suffering from endometriosis and adenomyosis. There's no endometrioma, but there is diffuse adenomyosis. AMH is quite low. Semen is normal. We know this is a quite a difficult case, but how do you actually can proceed with this case? Can I start with Professor Yusuf Latif? Or I think Professor Hemant Senanayaka can start with the discussion.
Yes, I think her best chances will be with IVF, really, with suppression to begin with. I think there will be no place for surgery here. I think given her age and the other limitations, and its adenomyosis, like reasonably sized uterus, the chances are best with adenomyosis. I would advise her on that, basically.
Okay. Sir, is there any provision of surrogacy in Sri Lanka in these cases where the uterus is like diffusely adenomyotic?
Sorry, I didn't understand the question.
Sir, is there any provision of surrogacy in Sri Lanka?
Surrogacy, no. We have no
Oh.
legal
Okay.
provision for that.
I'm sure it's not also in Pakistan as well.
What about Bangladesh?
No, we don't have it. So lastly, actually, we have come to I don't know whether we have another scenario to talk about. I think the last one is very common in our South Asian family, because we see that women come in the later 30s, about 38 years, they have long suffering from endometriosis. They have stage 4 endometriosis, their AMH is low, but they're absolutely unable to do any IVF because of financial problem. I want to ask from each of you, what would be the second best opinion for her? I mean, she cannot have IVF because we know IVF is the main option for her, but she cannot have it. So what might be the next thing we can actually tell her to do? Dr. Hemant Senanayaka?
Yeah, I mean, for me, it's fairly straightforward because we can offer her surgery in the state sector without charging any money. So that's available. But the unfortunate thing is that the levels of skill for the stage 4 endometriosis
Yes.
are not really available, and the levels of skill will be will vary a lot. Very sadly, people will still go for hysterectomy, offer a hysterectomy,
Yeah.
and then that might be an open hysterectomy rather than a conservative surgery. So this woman at least needs long-term suppression to relieve her of her symptoms.
Yeah.
And she can't undergo IVF for the fertility. So you can only give her a chance with surgery. So for me, that's, but I don't know what in another setting where the surgery also is not free. I wonder what the options will be then. It might
that
have.
would be less expensive than IVF in our country at least. What about Dr. Rubina? What do you want to suggest for her?
For Pakistan, in government hospitals, the surgery is available free of cost. So I think this patient needs a detailed counseling. A low possibility of conception, actually. And I think that we need to discuss with her. She's 38 years of age, dwindling fertility. In addition to that, grade 4 endometriosis. I think my first choice would be to make sure that we do the surgery and give her suppressive drugs to make sure that her symptoms are okay for a couple of years at least. And then review the situation, talk to her again. But adoption would be a good choice for this particular patient as well, so that the fertility needs are met and the patient is symptom free as well.
Okay. Do we have Dr. Jaideep Malhotra, Narendra Malhotra, anybody available to?
I don't think so.
I don't think so. Okay. Lastly, we'll take the comment from Professor T.H. Chaudhary. What would be your opinion in this case? Patient cannot afford IART.
Very difficult to advise in this situation. In our situation, I think we can't help her much unless there is somebody come forward to help her financially.
Yes.
But even with the money available, the prognosis is not very bright. So better to counsel the patient that it is better to adjust her life with the possibility that she will never become pregnant, or if she prefers, to adopt a child and bring it up as her own.
Okay, so I think another option for these type of patients in our country where she has no other options left. Thank you very much. I think it was a very fruitful and interactive and very interesting panel discussion. We have come to the end of our time. We had about 90 minutes time. Now the time is for giving vote of thanks. I want to give the microphone to Professor Herath from Sri Lanka to give his vote of thanks before we end. Professor Herath.
Sir, in general, like to comment.
Yes, yes.
Appa, stop the slide share, please.
Sir, chief guest হিসেবে in general একটু comment করবেন না?
কি আপা?
কিছু বলেন। স্যার।
Oh. So
chief guest হিসেবে স্যার একটু in general.
Okay, so let us give Professor T. Chaudhary the microphone again to give a few words about the webinar before we conclude the session with the vote of thanks. Professor T. Chaudhary. Something about this webinar, some comments about the webinar before you conclude.
Me?
Yes.
Yeah. Well, actually, respected chairperson of this webinar and the participants, actually, I enjoyed this webinar very much for two reasons. One, it is for its scientific value. The discussion has been quite practical, and it involves mostly the cases that we get in our usual day-to-day practice. I must congratulate Dhanendra for giving an excellent presentation, particularly about the preservation of fertility. Though up till now, we know apart from the modification of surgical technique, actual fertility preservation in the real sense is not required very much in case of endometriotic patients. We can manipulate our surgery and medicine combination in a different way in order to give them enough relief. And many of them will not actually require a ovarian fertility preservation in the real sense. But he has covered the fertility preservation on all its aspects. That is a good thing for our young gynecologists. They should know what is happening in this area. Second important is Jay's lecture is also good because he is actually giving hands-on training to our participants, and I think it is not a learning exercise for our participants, but also for him, because he will have enough experience to know how to give this training in the best possible way and how the candidates or participants can get the best from him. So I'm sorry that my internet connection was very poor this evening, and I missed occasional, talks, part of the talks. But in any case, I think the discussion, particularly the case scenarios, has been very good and practical, and I think the session has been conducted very well. But last and not the least, this webinar gave me an opportunity to meet many of the old friends, which otherwise would not have happened because of travel restriction. And thank you very much again. It is nice to see you all here. Stay safe. Thank you.
Thank you, Professor T. Chaudhary, for your valuable comments. Now I give the microphone to Professor Herath from Sri Lanka to give his vote of thanks. Professor Herath.
Good evening, everybody. It deems a great honor, privilege to propose a vote of thanks on this occasion of a scientific webinar on endometriosis and infertility, organized by the REI Subcommittee SAFOG. I thank the chair of this subcommittee, Professor Rashida Begum, for proposing a welcome address. And I thank today's center of speakers, Professor Shyam Desai, Professor Narendra Malhotra, and Dr. J. Mehta, for your brilliant talk on very difficult topic. And you made it very easy, understandable, and to the point. My sincere thanks to all the esteemed discussants, Professor Siddiq, Professor Jai Malhotra, Professor Rubina Sohail, Professor Hemant Senanayake, who despite their busy schedule has found time to grace this occasion. Thank you for giving a very thoughtful and evidence-based practical solution to very common scenarios of endometriosis. I also express my heartiest thanks to the excellent moderator, Dr. Tansina Sabina Chowdhury, for her very lovely and interactive moderation. I thank our two chairpersons, Professor Yusuf Latif Khan, Professor Farhana Devan, for their unstinted support for this society, guidance and encouragement in all the runaways we are running. My heartfelt thanks to today's chief guest, Professor T.A. Chowdhury, sir, for your gracious presence. We are grateful to all the audience from all over the SAFOG countries. I thank the media partner for investing interest in covering the event and all good hearts who worked behind the screen. Finally, I leave you this inspiring quote by Martin Luther King. An individual has not started living until he rises above the confines of his individualistic concerns to the broader concerns of all humanity. Once again, thank you all for your attention. Thank you. Good night.
Thank you, Professor Herat. That actually marks the end of our very, I think, fruitful and interesting webinar. So I say goodbye to everybody and good night. Hope you have a good night's sleep next and have a great time. Thank you.